Salam Media, coming to you live from South Africa.
Welcome back. You are listening to the Mario Mokwanda Show on Salam Media. It is 12:39 on this Tuesday and time for our Women's Health Tuesday. Today's topic of discussion is fetal macrosomia, not somnia, somia, fetal macrosomia. And Dr. Tom Mokaya, a specialist obstetrician and gynecologist, will be telling us more about this condition. Good afternoon, Dr. Tom. I think we have lost Dr. Tom there. Let us try again, Dr. Tom. All right, we will go back and catch up with Dr. Tom in a moment. We'll just give him a moment to sort out a few connection issues or whatever it is. You know, we have that. It's 2020. It's the year of I got disconnected. It reminds me of the Mixit days. Remember? Yeah, that's how old I am. I lived during the time of Mixit or MXIT, and we would always get DC'd, and it would be like, DC, LMP, last message, please. I kind of miss that. What was your Mixit name? I can't remember mine, but anyways, there were people who were like too hot to handle, too cute for you. Kind of the things that you see on the number plates today. If you see them on the number plates, you know that that person had MXIT. Yeah, it is just a way of letting you know that that's how old they are. So today we're going to be talking about fetal macrosomia. Dr. Tom Mokaya is going to be shedding some light on this condition. It is used to describe newborns who are much larger than average. And when we're talking about much larger than average, we're not talking about just three kgs or 4 kgs. I think that's a bit normal these days. We're talking about larger than that. Dr. Tom? I can see the ceiling of Dr. Tom's office over there. If you have any comments or questions regarding this topic, please leave them in the comment section below. We are live on Facebook. You can also send them to us on our WhatsApp line. The number is 061 766 0355. Alternatively, you can call us in studio. The number is 010 880 and there is Dr. Tom. Good afternoon, Dr. Tom.
Good afternoon. Good afternoon to you and good afternoon to your listeners.
Thank you for joining us once again, Dr. Tom. All right,
Hello, good
let's
afternoon.
get straight into it. Hi, can you hear me, doctor?
I can hear you very clearly. Can you hear me?
Yes. All right.
Yes, I can hear you.
All right, so what is fetal macrosomia?
Can you hear me?
Yes.
Fetal macrosomia, I suppose you can hear me.
Mm-hmm.
Yeah, now fetal macrosomia, if I may define the word macrosomia, macro means big, and
Yes.
somia is the body. So macrosomia is big. So fetal macrosomia is when a baby is born larger than what is expected. On average, babies are born between 2.5 to around 4 kilograms, 4.5 kilograms. So any baby that is born more than 4 to 4.5 kilograms is defined as a macrosomic baby. In some areas, they may use 4 kilograms. In some areas, they use 4.5 kilograms.
So basically, anything larger than 4.5 kilograms would be considered macrosomia. So, who is at risk of macrosomia or being pregnant with a
Yeah.
big baby?
Now, on average, in the general population, around 5% of babies that are born are found to be macrosomic. Now, the mothers who are predisposed to having macrosomic babies are the ones who have diabetes and where the diabetes is not well controlled. So it can be gestational diabetes, which starts when one is diabetic, when one is pregnant, or a woman who has been pregnant before, who has had diabetes before, and then she falls pregnant. She's predisposed to having a baby that is big. Two, mothers who have obesity, a BMI of more than 35, are predisposed to having macrosomic babies. And thirdly, babies who are mothers who have generally had a history of macrosomia, who have had a baby before who has big. So those are some of the mothers who are predisposed to having macrosomic baby.
Mm-hmm. And what about those who have had babies who were maybe around 3 kgs, just a little short of being considered macrosomia? Would that be a risk factor?
At times, if a baby has been born within what we call as a normal range, then the chance that one will have a macrosomic baby is not high, unless, of course, in the subsequent pregnancy she develops diabetes. And then there are
Okay.
some other chromosomal abnormalities which lead to babies being macrosomic. And there are very many of them, but fortunately, they're extremely rare. There's some genetic conditions which lead babies that are born to be born big. And something else that one is to know is that macrosomia at times can run in families, it can be genetic. If theoretically one was born very big and therefore they have a gene of giving birth to a baby that is big, then they can give birth to a baby that is also big. So macrosomia can also be genetic.
Mm-hmm. And how is it diagnosed?
Now, the diagnosis of macrosomia, normally one can be, if one knows exactly when they fell pregnant or an ultrasound has been done early on. So it can be a clinical diagnosis, which means somebody comes and theoretically we are feeling that this baby is supposed to be 30 weeks or supposed to be 35 weeks. And when we make the measurements, we find that the baby is more than what we call as the 90th centile. So if we are expecting the baby to be 2.5 kilos at a particular gestational age, suddenly we find that the weight is the height of the fundus when we measure feels much bigger. Then we can start suspecting macrosomia. So it can be a clinical observation, and it can also be done through ultrasound in mothers who have the opportunity of being followed up by a medical profession who follows up, who does ultrasound. Then we find that when we're expecting a weight of 3.5, suddenly we measure a weight that is much bigger than what we expect. So it can be done either clinical or by ultrasonography. That's how we're able to diagnose a macrosomic baby.
Mm-hmm. And what are the complications associated with having macrosomia?
Now, as one will imagine, if a baby is big and is 4.5, or even 5 kilos, some babies have been born even up to 5.5. Now, during pregnancy, once we make a diagnosis of macrosomia, it is critical that we make sure that we don't miss diabetes. So therefore, it is important to make sure that diabetes is ruled out. If we find that the mother has diabetes, the gestational diabetes, we make sure that we make the diagnosis and treat it appropriately. Because if the diagnosis of macrosomia is not met, or of macrosomia, and therefore diabetes is missed, that can lead to a baby being damaged or a baby even dying inside. Now, during labor, because the baby is big, one, there can be prolonged labor. Two, there can be what we call a CPD, where the baby fails to come out in due time, in due course, in due time not expected. And that may lead to a baby that goes into fetal distress, or a baby that stays in for a long time and gets damaged. At times, it can be so severe that the baby can have fetal demise. So one, it can be prolonged labor. Two, if the baby is very big and finally comes out, it causes a lot of lacerations around the perineal area, around the vagina. So it can cause a lot of tearing and damage to the pelvic floor. And because the baby is big, and at times the head can come out, but the shoulders refuse to come out, what we call in the medical terminology as shoulder dystocia, where the shoulders fail to navigate their way through the birth canal. And in instances like that, one has to have some form of experience to be able to deliver babies like that, because the head comes out. We call it the turtle effect, where the head comes out, but the shoulders remain inside because they're big. And if finally the baby is born, we find that these mothers also tend to have what we call as postpartum hemorrhage, where they bleed a lot after giving birth because the uterus does not contract and does not contract well. And therefore, there can be a lot of complications during birth. And in instances where the diagnosis has been made, it's obviously advisable that a cesarean section is done rather, and therefore macrosomic babies lead to cesarean sections being done more often.
Well, I was just thinking about that. I'm like, why don't we just consider a cesarean section if you're going to have all of those other complications post-birth? Now, how is it treated or is it managed?
Now, once the diagnosis has been made, all the tests have to be done to make sure that there is no diabetes. One, two, we have to do tests to make sure that there is no chromosome abnormality. And as you correctly say, once we've made a diagnosis of macrosomia, it is highly encouraged to plan for a cesarean section instead of allowing that mother to labor. And therefore, once that diagnosis is made, the mother needs to be transferred to a unit where cesarean sections can be done, and therefore the delivery should not be done in a unit where, one, you can't be able to do cesarean sections quickly. Two, if the mother bleeds a lot, has what we call as PPH, where it cannot be appropriately treated. So the management of macrosomia is to, after making the diagnosis, transfer the patient to a unit which has medical professionals who can be able to treat it, and the delivery of choice is a planned cesarean section.
All right. Yeah, well, very interesting discussion, your macrosomia. And can you prevent having an overly big baby, especially if you are not diabetic?
Yes, one of the predisposing factors of fetal macrosomia, which I didn't mention, is excessive weight gain in pregnancy. So one of the ways in which one can be able to prevent it is to watch their weight when they are pregnant, which means that during the follow-up, if your medical professional notices that there is more weight increase than normal, then one can be able to adjust their diet appropriately. So one of the ways in which one can be able to do that is to watch their weight, not necessarily to starve themselves and make sure they don't pick up any weight. Weight gain in pregnancy is a normal physiological phenomenon, but excessive weight gain is the one that may lead to macrosomia, and therefore one can be able to watch their weight so they don't pick up excessive weight during pregnancy, which will therefore lead to macrosomia.
Oh, my child was not far from being a microsomic baby because she was born at 3.8. Phew, I'm glad. But thank you so much for your time, Dr. Tom, and thank you for the discussion as well.
Thank you. Thank you so much for having me.
All right, so that was Dr. Tom Mokaya, an OBGYN, talking about fetal macrosomia. And as I said, yeah, my baby was just a few kgs short of being, was it kgs or grams? Yeah, yeah. Either way, she was born at 3.8, so she would have been a macrosomic. Ooh. I'm glad we didn't get to that part because who knows what would have happened. But she was a heavy baby and very chubby. In fact, when she was born, I was like, "Hey, is this my child? She looks like a sumo wrestler." But anyways, if you have any comments, questions, or queries, please leave them in the comment section or send them to us on WhatsApp. The number is 0617660355. Do stay with us. Be right back.